Hello and welcome. I'm Josh Tarini, Diabetes Clinical Specialist and Registered Dietitian with Medtronic of Canada, and it's my privilege to hold an exciting educational event today. The title of our event is called Interpreting Medtronic Continuous Glucose Monitoring and Medtronic CareLink Data to Advance Diabetes Patient Care for Healthcare Practitioners. And I'm excited to be alongside two experts, Dr. Bruce Perkins, Dr. Ohad Cohen, to join the session today. So let's take a look at the agenda for today. We will be going through a clinical evidence review with Dr. Bruce Perkins. Bruce Perkins is an associate professor and endocrinologist at the University of Toronto and Mount Sinai Hospital. We'll then switch gears and take a look at Medtronic CareLink and a couple of case studies led by Dr. Ohad Cohen. Dr. Cohen is a professor at the Institute of Endocrinology in Israel. During the session, you will all see at the bottom of your page that you have a few icons to use to help facilitate the process. There is a QA icon where you can ask questions. You'll simply type in the question and hit submit at any time. We will take a couple of breaks as we move along to address those questions. We will also have about a 15-minute period at the end of the session where we will address those questions. Anything that we don't get to, we certainly will respond to thereafter. There's also a little icon at the bottom of your screen for the bios for our two participants so that you can see their full bio. And there's also a resource icon at the bottom for a couple of informational slide decks that may be helpful thereafter. So the learning objectives for today. So after attending the webcast today, you will be able to distinguish patterns in blood glucose data that can help diagnose challenges in achieving optimal glycemic control, apply methods that will allow for the interpretation of Medtronic CareLink to improve glycemic control, to understand how to better utilize continuous glucose monitoring, and to review recent clinical evidence. Before I turn things over to Dr. Perkins, I will give him a full introduction. Dr. Perkins, as I said, is an associate professor and endocrinologist at the University of Toronto and is a diabetes complications clinician scientist. Dr. Perkins trained at the University of Toronto, Harvard University, and the Joslin Diabetes Center. Dr. Perkins currently practices at the University of Toronto Leadership Sinai Center for Diabetes, Mount Sinai Hospital, just down the road in Toronto. So without further delay, I'll pass it over to Dr. Perkins.
All right. Thank you so much, Josh. It's great to take part in this program, and it's great to see you as well, Ohad. So I hope this will be a dynamic morning. We're going to start, though, with the need-to-know stuff. And in any aspect of medical practice, we need to understand what the level of evidence is and the degree of evidence behind the things that we do. So just to sort of expand on that objective of reviewing the objectives, I'd hope that in these next 20 minutes or so, you'd be able to cite the key studies that support CGM in clinical practice, understand some of the methodological limitations in the randomized control trials of this area, and to describe these recent 2013 publications that are focused on specifically hypoglycemia prevention strategies using the technology. So the way I'll do that, if you look on the left bar, I have a little bit of background. I'm going to go through the sensor-augmented pump and continuous glucose monitoring specific studies, then the hypoglycemic strategies using continuous glucose monitoring, and then I'll summarize. So this will be a pretty rapid segment, I hope, not to slow anything down. So the first thing, by way of context, our biggest problem, I think we would all agree, and I could talk for more than 20 minutes about this, is the concept of fear of hypoglycemia in clinical practice. It sabotages so much of what patients do and even what providers do to get target A1C. And so to me, a big question is, can we replace the hypoglycemia awareness that's physiological? So are we sensing hypoglycemia? Do we feel confident that if we're becoming hypoglycemic, our bodies will tell us that this is happening? And we know that this is generally in longer duration diabetes, but can happen to anyone, even with short duration diabetes, after a hypoglycemic event, after a bout of exercise, etc. So can we replace that awareness with technological hypoglycemia awareness? Can we now trust a device to help us with that awareness? So the first thing that I wanted to focus is on the Canadian Diabetes Association clinical practice guidelines, which are kind of known internationally as a rigorous evidence-based process. And in recent guidelines, there's now been enough evidence to suggest real-time continuous glucose monitoring for improving glycemic control and for reducing hypoglycemia. These have what's called level 2 evidence. It's rare that anything in the device industry will have level 1 and grade A evidence, simply because we can't blind these interventions and studies the way we can blind medications with placebos. And I'm going to get into some of the citations in this statement here from the key messages of the CDA guidelines. So to start with, I thought I'd describe a publication just from last year from the Cochrane Collaboration. So as many of you know, the Cochrane Collaboration has a number of sites internationally, and they do systematic reviews, meaning they take data from multiple studies around a specific question, and then they put together a summary measure of their effect. And the Cochrane Collaboration has a publication around continuous glucose monitoring for type 1 diabetes. And they make I've kind of dissected out of this 150-page document a number of key points. The first is that the evidence is strongest to support the use of continuous glucose monitoring to augment pump therapy. So using it in combination with an insulin pump. And the key studies there, though there are some others, are the Star3 and the Eurythmic Study. So I'm going to describe these in a little bit of detail. So you may have some familiarity with Star3. Star3 was a North American venture in the US and Canada. They randomized over or nearly 500 patients with type 1 diabetes who generally were around the age of 40 and had in excess of 20 years of diabetes duration. But they accrued people from pediatric and adult groups, so there was a lot of variation. And here the baseline A1C was about 8.3. And in the control group here were people who continued on analog-based multiple daily injections, and they maintained an A1C by the end of the study at 8.1%. But those who went to a sensor-augmented insulin pump had a big reduction of about 1% in the first 3 months and maintained that and ended up with an A1C of about 7.5%. So the incremental A1C benefit of using sensor-augmented pump therapy combined to MDI on average was about a 0.6% better A1C. Now just maybe note that both of these groups used CareLink, an online resource for uploading and interpreting and reviewing data. They had really, both these groups had full standard of care, but they were a group of patients who were failing to reach targets at the beginning. And the other key point from this study was that maximal A1C reduction was seen in those who were using the sensors the most. So that's obviously a post hoc analysis, because it's a subgroup analysis in the end who used it the most. Well, turns out those people had the best A1C reductions. And in fact, those who used it 80% of the time had A1C reductions of about 1.3%. All right, so the other thing about the Star3 is that we later published on the continuation phase to see if the effect was durable. And those who improved their A1Cs, they continued to up to 18 months after randomization. And those who then transferred over after a year from MDI to sensor-augmented pump therapy had a nice improvement as well. There's no question hyperglycemia was decreased. We know that from A1C. And here on the histograms on the left, you can see the blue sensor-augmented pump therapy and red MDI. At baseline, they had similar intensity of hyperglycemic exposure. That's what an area under the curve for hyperglycemia is. But by 1 year, that decreased substantially. But on the right side, we don't see a nice improvement in the area under the curve for hypoglycemia, or the intensity and frequency of hypoglycemic exposure. In part, this is because it was a low-risk group for hypoglycemia. So you could say the extent and duration of hyperglycemia in sensor-augmented pump therapy was much less compared to MDI. It was 1/3, but not so for hypoglycemia. So maybe to prevent hypoglycemia further, we need more measures. But the other interpretation is that this was a group that frankly was having very low levels of hypoglycemia, like about 1/4 of the rates that we saw in the Diabetes Control and Complications trial, DCCT. All right, so then just briefly, there's a European version of the Star3 study. That was called the Eurythmic Study. Here they had 83 people in a number of European centers. Their A1C was a little higher at baseline, and they had a beautiful incremental benefit, actually, of 1.1% over 26 weeks. And so in the Cochrane Collaboration, here's a forest plot showing the effect on A1C reduction in these different studies. The fact is we can take an integrated A1C reduction of a range of 0.6 to 0.7% over 6 to 12 months. So now what I want to do is go on to the studies that look at the effect of continuous glucose monitoring alone, because you realize the ones I just mentioned are those where it was a sensor-augmented pump versus MDI. Here this is looking in different contexts at the effect of sensors on their own. And the key study is the JDRF CGM study group. And here in this publication, they had 3 tertiles of age. And those who were 25 years or above, there was nearly 100 patients, they had over 6 months about a 0.5% better A1C compared to those who were not using CGM. But we didn't see differences in the younger adults or the children in that group. Now, they also had another project, the JDRF CGM group, and that was to look at people who had A1Cs that were less than 7%. And in that group, of course, they didn't really see an improvement in A1C. In fact, they saw a trend towards better A1C compared to those who were not on CGM. That's what that little table above shows. But the real finding was that if you looked at a composite endpoint of some improvement in A1C, decrease in hypoglycemia frequency, this was always much better in the group wearing CGM. So here's our first clue that if you do have someone on target, these are the people we seem to have been ignoring in all these studies. We always take people with high A1Cs, but if you take people on target, the use of CGM does decrease hypoglycemic events. So, and then finally there are, for this effect of CGM alone, in the JDRF study, it was a mix of people on pumps and on MDI. But the switch study, which was published last year, was in a group of people who were all on pumps. And so they were started on pumps, and then they went through a crossover design where in the first 6 months, half were randomly assigned to having a sensor off, the other half to sensor on, and then they had a little washout period in between, and then they did 6 months of the opposite. So, and they had very similar patients to Star3 in it. And here what we saw was a big improvement in A1C, as you can see on this top graph. The dotted line is the sensor on. And then the sensor off group, they had stable A1C, but later when they had sensor on, had a nice decrease. And so overall, they also had a pediatric subgroup, but overall we're seeing A1C benefits in the range of 0.4 and 0.5%. Kind of similar to the adult population in JDRF, but here applying to everyone, children and adults. But one of the key points of this study, if you look at that washout phase, for me, in my heart of hearts, I believe that if someone's on CGM for 6 months, that they're going to learn things about it. They're going to learn about basal rates and how to better carb counts and learn about insulin dosing. And then that's going to pay off even when they're off a sensor. But there's not great evidence that that's true from this study. Once someone's off a sensor, their glycemic control worsens or rises again. So the key point number 2 from this Cochrane collaboration was that the evidence to support an independent effect of continuous glucose monitoring is reasonably strong. We see, I didn't describe all of these studies. There are others that you may be familiar with, like Earl Hirsch's Treat to Target or Denis Racah's Real Trend study. But if you look at all of these over the course of 6 months, you'd expect a 0.2% incremental benefit of CGM. And Switch, which was published after this Cochrane systematic review, showed more like the 0.4%. So the real value is somewhere between those. So our body of evidence so far for A1C reduction, CGM alone from the evidence is responsible for 0.2 to 0.4% of an A1C improvement over 6 months. And the sensor augmented pump compared to MDI is responsible for more. And then I'm not getting into these details just to keep things brief, but I'd say the third key point from the Cochrane review was that the evidence for intermittent use of real-time CGM reflects what we saw in Switch study, where the A1C benefits lost after continuous use is discontinued. But I'd say there's one exception, and that's that GUARD control study from 2006, where they actually used biweekly sensor use, so 2 weeks on, 2 weeks off, and they had a nice A1C improvement in that study. But otherwise, the rest of the evidence suggests that if you're going to get A1C benefit, you need to be wearing your CGM, which depressed me a little bit, but seems to be the reality. And then finally, the retrospective blinded CGM, like an iPro2 style thing. The evidence for A1C benefit, there's very few studies in that area. And in my heart of hearts, I believe this could still be very useful, and particularly in type 2 diabetes. All right, now I'd like to talk about those CGM when it's applied to protocols to help prevent hypoglycemia. And I'd say this is the more interesting part of my 20 minutes. And that, to begin with, is a publication from July in the New England Journal of Medicine that I hope most of you have at least heard of or seen, but here's your chance to know all the details from it, or the key details. So this we refer to as the ASPIRE InHome trial. This is a good acronym. It actually adds up with the letters. So automation to simulate pancreatic insulin response. And in this study, it was led by Rich Bergenstahl and was also industry funded, I should note. In this study, they used a sensor-augmented pump that's like our Veo here, or actually it was the Veo that we use, with the low glucose suspend, or what you hear from the US being referred to as threshold suspend, versus a standard sensor-augmented pump where the low glucose suspend feature is not on. So they use the US version of our paradigms called the Revel. So just to be clear, one group just had sensor-augmented pump therapy, the other had it with a automated low glucose suspend feature. And just to describe that briefly, here you set a threshold on the pump, and it was set at 3.9. If a sensor reading falls below 3.9, unless the patient interacts immediately, it will shut off basal for 2 hours. So this is not how we treat hypoglycemia generally, but for someone who's not aware of their hypoglycemia, it's taking some action to prevent the severity and potentially the duration of that hypoglycemic episode. So they took, the average patient in this study was, and there were about 250 people, was a 43-year-old with 27 years of type 1 diabetes and A1C that was just above target at 7.2 and no recent severe hypo or hospitalization. And in a run-in period for 2 weeks, they wore a sensor 80% of the time or more. So quite a few people fell out of this study because they didn't adhere to the sensor fully, but there was still a very big proportion that did. And it was a 3-month randomized control study, multi-center, and of course open-labeled. And the primary efficacy endpoint here was not A1C improvement, it was the area under the curve for overnight hypoglycemia from 10 p.m. to 8 a.m. All right, I think I described that study well enough, probably a little too much. So let's get on to results. So the first outcome was a safety outcome, and this is, to me, this is beautiful. A1C was the measure of safety. In other words, if you're going to shut off someone's basal now and then, are you going to mess up their overall glycemic control? And the answer is no. So they had very stable trends towards little decreases in A1C over 3 months. But the key thing is the area under the curve, the efficacy measure. So remember, area under the curve, you can picture a CGM output. It's if you drew a flat line at the 10 line, or here, in this case, for hypoglycemia, at the 3.9 line, you're measuring the area under, between the curve and that threshold line of 3.9. So why don't I just describe this for one moment, since I think I'm doing well for time. If an area under the curve, what we're seeing here in the threshold suspend group, they have a mean of about 1,500, same as in the control group. But then, but the end of the 3 months, the threshold suspend group had a much lower value. It was 980, whereas the control group was up around 1,500. So you could say the difference between the 900 and the 1,500 is about 600. And the area under the curve units are in milligrams per deciliter minute. So That's American units, probably Israeli units, milligrams per deciliter. So in our units, we would divide by 18. So the 980 and 1568, that's about 600 difference. So it's in minutes. So if we made it in hours, that would be about 10. And 10 in milligrams per deciliter is roughly half of one of our units. So you could say that on average, people are getting half a millimolar of blood glucose less hypoglycemia over a full hour. That didn't make any sense. Did that make any sense to you, Josh? The idea is that there's less hypoglycemia. It's tough to describe area under the curve, but it's a measure not of just how much hypoglycemia, but the intensity as well. So the extent and duration of hypoglycemia was a third lower compared to the control group. And we can look at that as proportion of the sensor values below 3.9, and that was decreased by about 40% no matter what thresholds you use, are 3.9 or lower values. And on top of that, the number of discrete events, so the number of hypo events, so you could have a level less than 3.9 for an hour, but that's still one hypo event. But for the analysis where they use the proportion of sensor values, you're adding up each 5-minute interval. But here the discrete events were 1.5 versus 2.2 events per patient week. So that means per patient for 1 week, they're getting 1.5 episodes of hypoglycemia rather than 2.2 if they were using no low glucose suspend. So it doesn't eradicate hypoglycemia, but you can see it's reducing it substantially by 30%. And then the combined daytime and nighttime was also about 30% lower. All right, and the final thing that we needed to see in this paper was what happened in those who had suspension. Did they go into DKA? The answer is no. And did they get high hyperglycemia? We know it wasn't so substantial that their A1C would rise, but here it shows us over the suspension period where the blood sugar ended up. So if it was less than 3.9 at suspension, at the end of the 2-hour period it was about 5, and a few hours later it was about 9. So it really didn't seem to be messing up people's glycemic control either. And then I should also note there were no severe hypoglycemic events, so needing third-party help or assistance or seizures, coma in the low glucose suspend group, but there were 4 that required assistance in the control group. All right, and then my very last study that I think would round out your knowledge. If you know just these studies, you know everything around CGM, and that is what we can refer to as the LY study. The primary author was LY, L-Y, an Australian study, which was the exact same concept, the same devices, but here the average patient was completely different. They were much younger, less duration of diabetes, A1C similar, just above target, but they included patients who had near total loss of hypoglycemia awareness. So they have a scale here that's basically a Likert scale score on hypoglycemia awareness. It's those people who had the worst degree of awareness who were brought into the study. And they did this in about 100 people over 6 months to look at the efficacy endpoint of how much moderate to severe hypoglycemia occurred. And in that study, it's a little bit complicated, so I'll just guide you through this one. So unfortunately, from a data perspective, this one's not easy to see the results. But here we see the incidence rates. And what I would just highlight, in the pump group alone, there were 20.7 events per 100 patient months. So if you followed 100 patients for 1 month, you'd expect 20 bad hypoglycemic events at baseline. And baseline was retrospectively the last 6 months before they were brought into the study. And here you can see there was a failure of randomization because the sensor-augmented pump group had like 100. The people who just happened to be randomized to that group in the last 6 months had so many more events. They all had an event or more per month. But by the end of follow-up, the incidence rate per 100 patient months adjusted for the baseline level was higher in the pump group and substantially lower in the sensor-augmented pump with low glucose suspend. went from 129 to 9.5. Now, the actual number of events weren't so different between the groups, but when you adjust for the fact that we had a much higher risk group in the low glucose suspend, it's a lot lower. And so you could summarize by saying that someone on low glucose suspend, rather than standard sensor-augmented pump, would be, over 6 months, 3.6 times less likely to have moderate to severe hypoglycemia. And they had many proportion of hours spent in hypoglycemia was much less as well. So there's the evidence. So we can summarize, I think I'm on time, with the approaches that overcome the challenge of A1C reduction and the approaches that overcome the challenge of hypoglycemia reduction. So by way of A1C reduction, we know that trials of CGM alone demonstrate modest A1C reduction in the range of 0.2 to 0.4% over 6 months. And here the key study, you could say, is the JDRF study and the SWITCH study. Secondly, trials of sensor-augmented pump therapy demonstrate more marked A1C reduction as compared to MDI without excess hypoglycemia. And that's in the range of 0.6 to 0.7, and the main data comes from Star3 and the Eurythmic Study. And then for hypoglycemia reduction, the low glucose suspend is associated with substantially lower risk of minor hypoglycemia and major hypoglycemia incidence, as well as lower intensity and duration of hypoglycemia. And that comes from these two studies this year, the ASPIRE study and the LIE study from Australia. And this has been demonstrated because of those two studies in lower risk and really, really high risk hypoglycemia populations. So that is the evidence. And I'm just, before I take a question, I need to do a personal plug because there are a lot of you from around Canada right now who are at your computers. And I just wanted to, actually I'm going to come back to that slide in a minute. I want to remind you about our diabetes longevity study. We are looking for people with 50 years of diabetes or more to do a questionnaire this year, and then we're going to involve them in studies in subsequent years. We would definitely want for you to spread the message. Make sure you let your patients know who might be in that ballpark of diabetes duration about this toll-free number and this website, diabeteslongevity.ca. That was my plug, but maybe I'll return to my key message, which is now it looks like we can implement technological awareness. Remember in my introduction now, this is a slide that I've borrowed from Rich Bergenstahl, where on the top panel you see that someone had hours and hours of hypoglycemia before they had a seizure. It's an unfortunate case. And you can see that their insulin delivery is programmed so that during that time they were hypoglycemic, there was a pre-programmed rise in the basal rate. And on that night, that's definitely not what they needed. And the fact that our devices have the ability to detect hypoglycemia and adjust how a basal is delivered really means that we need to commit to this kind of technology to help our patients with type 1 diabetes. So with that, I'll return the podium to Josh.
Thank you so much, Dr. Perkins, for that excellent review of the evidence as it relates to CGM and type 1 diabetes. In terms of where we've been so far with the research, what do you think a natural progression might be about where we should go or where we will go in terms of future trials as they relate to CGM and type 1?
Yeah, well, this we can see in two regards. The first thing is that is what kind of algorithm is used. So here we're using an automatic pump shutoff at a specific threshold for 2 hours. And that's a pretty simple intervention. Maybe there is a certain trajectory of hypoglycemia or trajectory of blood sugar before it reaches hypoglycemia where we would choose to decrease basal or shut it off for a shorter period of time. And there might be other situations where we would safely say that we would do it for a longer period of time. So we have to refine that algorithm. I think this is an awesome first step. The second thing, of course, is here we're focusing on overnight hypoglycemia. We really need to have better algorithms that help to integrate decisions around bolus insulin and basal during the day to prevent hypoglycemia. But the real fear sits with overnight hypoglycemia, so it was a good starting point.
Excellent. Well, we'll look forward to those future publications down the road. Just one final question. Being that the evidence is certainly growing and is quite complex, if a patient comes to you and asks for a quick synopsis of how pump and sensing and perhaps LGS can help them, how might you synthesize that in a very short way for a patient to make it easy to understand?
Yeah, that's a good question. I wish I'd thought about that one before. The first thing is knowledge of and adapting to the technology, because what any publication has to have a consort diagram that gives you an idea of how many people were approached about the study, how many said yes, and then of those who said they're interested and were screened, how many failed for a number of reasons and why. And so one reason that people do is adopting this, actually wearing a sensor every night, essentially 24/7, so that they could get the benefit of a low glucose suspend. So my first thing is to say, well, you need to make a commitment to adopting the technology and understand that whenever you manage a piece of equipment, it's not going to be perfectly easy. So you got to understand that and dedicate yourself to that. The second step is you've got to be on effective pump therapy, which means you need to have evaluated basals, understand carb counting and your correction ratios, and have tested them out. And that's where we get evidence like from Star3 and Eurythmics. And then the final step is gaining the confidence to let a machine take over with some of the decision making, like stopping a basal, insulin overnight. I hope that answers your question.
Yeah, absolutely. I think it's, as the body of evidence gets more complex, it's nice for us to be able to synthesize it into the take-home points for our patients. So before we move on to our next speaker, I will give a little shout out to the audience. So don't be shy with your questions. You can go to the bottom of your screen. There should be a QA button that you can type in a question. You can hit submit at any time through the talk, and towards the end of this session this morning, we'll take about 10 or 15 minutes and entertain as many of the questions as we can. Any questions that we don't get to, we will actually be able to address thereafter from follow-up. So we will move forward now, and I will reintroduce Dr. Ohad Cohen, a professor at the Institute of Endocrinology, Sheba Medical Center in Israel. Dr. Cohen's very involved in clinical research and active in educating the use of technology to help manage diabetes, including insulin pumps, continuous glucose monitoring, and web-based software for diabetes management. Dr. Cohen received a position of associate professor in internal medicine at the Sackler Medical School in Tel Aviv, Israel, in 2007, where he continues to practice today. Dr. Cohen.
Thank you, Josh. Thank you very much. So we heard now with a beautiful presentation on the data that using technology to improve our patients' diabetes control is done by using different devices, either from the monitoring point of view, the continuous glucose sensing, or the non-continuous sensing by using blood glucose meters on one side, and using the injector device or the delivery device, the pumps. But what was very apparent very early, that it is the integration of the data from the sensing and from the pump which increases the advantage of using these devices. Because while you're measuring and getting data on the blood glucose control from one side, you can have additional information by looking at the human factor, or how the patient itself uses this data in order to change the way that he is interacting. That is, how much is he bolusing, does he change his basal rate? This information, this important interaction between the data and the human behavior is a crucial point in getting better results from using technology. Now, this integration is very difficult because there's a lot of data coming both from the sensing and a lot of data coming from the pump. And this can only be done by using some help from computer, web-based or computer-based management software. And this is the topic of my talk, will be the use of this therapy management software to enhance therapy to our patients using the common technology. So the web-based data management systems is the way to gain or to integrate the data and the human behavior. But the tool to look and to gather the information, and this is very important, is the use of the Bolus calculator, or in this case called the Bolus Wizard. Now the Bolus Wizard is good for all those who are involved in the treatment of the diabetes of this patient. On one side, for the patient, It's important to use the Bolus Wizard because it assists him in deciding what bolus he should give. And that depends on the amount of carbohydrate that he's planning to eat at that specific meal and on the levels of his glycemia at that specific time. So it helps him to calculate. But it also helps him to take into account previous boluses because it takes into account the active insulin from the previous bolus. And by that, it prevents him from over-bolusing or going into hypoglycemia because he was unaware of his previous boluses. And this is from the patient side. How about the side of those who are taking care of the patient, of the team of physicians, educators, dietitians who are following this patient? For us, using the Bolus Wizard gives us an opportunity to follow the patient's behavior. Because every time he uses the boluses, even though he's not aware of it, it's like a diary entry into his data bank. So using the Bolus Wizard is the heart in order to get good data to then to interpret it using the data managing software. Now the software and the downloads had an evolution. They started with like paper logbooks, not very far low, and there's still people using paper logbooks. And then through Meter software, CareLink, and now the CareLink 3 software management system, which enhances our understanding and the interpretation of the data, both from the sensors, from the glucometers, and from the patient's use of their pumps. The product that we are dealing with, the data managing system that we're going to show you and to explain how to use it the best we can, is called the CareLink. The CareLink software system has two surroundings where it is used. One is in the patient's home or the patient's surrounding, where the patient actually downloads the data at home, in the internet cafe when he's traveling around. It is a web-based software program where he can or she can download the data. In the office, on the other hand, there's the CareLink Pro system, which has a different way to present the data, and they can interact. So the physician, if he has the permission of the patient, can access the data that the patient is actually downloading at home. So the access can be either from the patient's download at home, or it can be downloaded at the physician's or the clinic, and they can interact through a common server, which is secured. So what is the importance of using these data management system? It can pinpoint the issues that the patients need to know in order to improve the glycemic control. It can answer whether there is a compliance issue. Does the patient inject, not inject, count carbohydrates, does not know how to count carbohydrates? It can also show if there's gaps in his knowledge, if he understands how to use consumables, how to use the meter, how to use the pump adequately. It can also address how good you are as a physician or as an educator. Are you doing a good job giving him right basal rates, or that the settings in the pumps are appropriate? All this can come out from looking at the downloads in a very simple and straightforward way. How does it look? What are the reports that using these data management system prints out that we can work with and to follow our patients? Well, there are 5 reports, but I will dwell mostly on 4 of them. One of them is the adherence report. Then we have the daily or the overview. We have the logbook, which is not used a lot these days because people are moving away from looking at the data in a sporadic way or in a manual way, and moving more to a presentation which looks at the data in the big pictures, like the daily overlay. You can also see the pump setting, very simple. And then you have to have the daily detail to make sure that what you see in the big picture is also correct on the day-to-day usage of the pump. So let's go quickly through those reports and see how much information we can gain from looking at the reports, which was very difficult for us to see when the patients were not using the downloads or were just using manual diaries and coming at home. So I believe that the most important report would be the adherence report. The adherence report gives us a very nice picture on the patient's general attitude towards his diabetes, I call it, or his psychological sheath. Because it, on one side, gives us the amount of glucose measurements that the patient is doing. Is he measuring enough blood glucose per day? You know that it's necessary to measure between 3 to 4 as a minimum when using pump therapy in order to avoid complications like diabetic ketoacidosis. It can also tell us how much the patient is using the continuous glucose sensing, as was mentioned before. In order to get good results of using CGM, we need more than 60 or 70% of the time usage by the patient. In this case, we can see that he's using it less than 50%. So he's not utilizing the CGM as required to get the best results. Then we have a very important insight into the way that the patient is bolusing. Because the bolus event part, it's the middle part of this report, is very difficult to gain if the patient is not using the wizard and is not using the downloads. Because it tells you exactly, is the patient using the boluses accordingly to the plan? That means, is he counting carbohydrate? Is he measuring? Is he giving an exact bolus based on these two data information? Or does he just do manual boluses? That is what we call the guess bolus. Just how I feel it is, how much I think I should give according to the way that I subjectively feel. We know that this subjective feeling is sometimes good, especially in the beginning, but as time goes by, sometimes you lose the ability to sense exactly where you are. So the bolus event part of the adherence report is very important to gain insight into the way that the patient is bolusing. It also tells us some clues regarding the plan of, let's say, the basal insulin plan. Because if the patient has many boluses, which he needs to have a correction done, that means that he starts the bolus when the blood glucose is out of range. If he has many blood glucose boluses when he's out of range, that means there is a hint that maybe the basal is off, that something is wrong with the plan. The override part is also very interesting because that tells us the amount of belief the patient has in the recommendation of the Bolus Wizard. If the patient always overrides what the Bolus Wizard recommends, it's not good. That means probably maybe he is right or maybe the recommendations are wrong and you have to change the settings. But on the other hand, if the patient does not do any overrides, that means he automatically does exactly what the wizard does, it's also not the best policy because maybe he's not using some of the sense of what's going on with his life when he's bolusing, because some of the information is very subjective. Is he going into sport a couple of minutes later? Is he feeling well? And so on. We'll continue to the other part, and that is the priming events, because that gives us a hint on how much or how good the patient is utilizing the consumables. Because every time he's changing the reservoir, we'll have a hint at the rewind. There will be another one or number at the rewind column. In this case, we can see that he's not changing the reservoir. Something is wrong here. When the primes are on, that means that probably the patient is also changing the catheter. The last part is the suspension. Patient who is suspending a lot, the pump is not using it, and it's important to us to have this information in an objective and easy way. And I'll just show you the example of two patients. One patient is what I call the anxious patient. What we can learn from this patient, just looking at the adherence report, that he's doing a lot of blood glucose reading, and he also does a lot of bolus wizards, or he's bolusing many times a day. This is not the perfect policy if you want the patient to do something else or just take care of his diabetes. On the other hand, the rewind shows that he's not using or is not changing the consumables according to what is recommended every 2 or 3 days. The opposite patient is the next patient. The next patient is the opposite, the one who is denying that he has diabetes at all. Because what you can see is that some of the time he's measuring blood glucose, but some days he's not measuring any SMBG, does not do any finger pricks to measure his blood glucose the whole day. It doesn't prevent him to do a bolus. Very dangerous patient. And you can get these results by looking at the download, just looking at the download. You don't have to pry, you don't have to interrogate the patient, you don't have to confront him, just look at the data and then work with the patients on the data that you get from the adherence report. The sensor overview report is interesting because it gives you a graphic representation of the glycemic control during an interval that you choose. In this case, 2 weeks in 2009. It looks kind of scary. But it gives you that, at least from a glance, that this patient is out of control, right? But if you use the sensor, the CGM, you get additional information. It's in a nice graphical way. It gives you a more topographical map of the blood glucose levels where the glucose is high many times during the day. It gets darker, like in this case during the night. And after the meal, if it's only once went high, like in this lunch meal that we see it's very light. That means that there's not a major issue with lunch, and it was a one-time effect or one-time occurrence that you don't have to deal with this, and you can continue to the next report. Again, when you look at the overview by looking at blood glucose measured by blood glucose with SMBG versus the CGM, you can see that the same patient at the same time, while using non-continuous sensing, looks very difficult to understand. Using the continuous glucose sensing can give you a more insight into pattern recognition, pattern problems, and to better pinpoint the issues at hand. The pump setting is a way to look at how the patient is actually programming his pump. Is the program according to what you believe that the patient should be using? And that is on the left, the basal, in the middle, the bolus settings, and on the right side is the sensor alarm setting, which you usually kind of neglect, but this is a very important part of treating our patients. Because we, as we talked before, want our patients to stay using CGM as long as we want, as long as they can, more than 70%, more than 80%. And one of the main reasons for the patients to leave the CGM is what we call alarm fatigue, turning on all the alarms, the high alarms, the trend alarms, the low alarms, and the low glucose suspension alarms. So as a physician or as a staff member, if it's a dietitian or educator, the opening of specific alarms should be done with a lot of thought and to make it fit the needs of the specific patient. And you can get this from just looking at the setting snapshot and to know exactly what's going on with the patient's settings that needs to be changed. So let's go into more practical issues. How can we define the need, the basal rate has to be changed or not by looking at the downloads? Well, there's several hints to know if the basal rate is accurate. One, just look at the patterns, pattern recognition. The second is look at the pre-meal glucose levels, because, and the third is to see the sum of the correction boluses and the overrides. I'll just spend a few minutes on these issues. The daily overlay patterns is very simple. You just look at the overlay, and we'll see it in a moment, and you'll find out where are the areas of concern. But the pre-meal glucose is very interesting, because in the past we would suggest to patients in order to check the basal rate, to do what is called meal skipping. Let's say, stop, don't eat the meal at breakfast, and just follow your blood glucose throughout the day. If your blood glucose level is going high, that means that the basal rate is too low, and the opposite. If during a meal skipped, the blood glucose is decreasing, that means the basal rate is too high, and you have to change it accordingly. But now when you use the downloads, the patient themselves do what's called automatically skipping a meal, because sometimes he eats lunch at 1 o'clock, sometimes he eats lunch at 3 o'clock. And when you look at the downloads, all these meals are aligned at the same time, so you can see the levels of the glucose before the meal, whatever time he ingested that meal. So it obliviates the need to do the skipping of the meal and to see if the blood glucose levels before the meal is according or in target. That means probably that the basal rate is probably good as well. The sum correction of boluses and overrides also gives you a quantitative assessment on how far the basal rate is from what is needed to be. And this is not clear only basal rate, it's the basal rate and the boluses, but it gives you some kind of a quantitative assessment. If the patient needs to add a lot of corrections, in each of his bolus, and the correction, and the sum of the correction is high, that means he's missing a lot of units in his basal rate program. So let's see how it looks on the reports. So the pre-meal glucose, looking at the overlay, is quite clear. When you see that before the meals, the patient, and like in the case in front of us, the patient starts the meal when he's in target, makes us to believe that the basal rate during the daytime is quite adequate. While looking at the pattern in the top box, you can see quite striking that there is a dark line above the target during the nighttime between midnight and 6 o'clock. So again, it hints to the issue that during the night the basal rate is too low, but during the day probably the basal rate is fine and fitting.
Wouldn't it be nice if a bolus lasts for 3 to 5 hours, let's say 4 hours on average, if you could hit a button, it would remove it would only show the sensor lines when bolus is not active, and then you would have an idea of basal assessment. So for example, on the upper overlay, you see the few red areas where there's hypoglycemia early in the night and fairly long duration. Are those occurring when there's bolus active? Because someone who's fearful of hypoglycemia will say, Dr. Cohen, those make me want to decrease my overnight basal, but in reality, I agree with you, there's a drift up in most of those lines. So then you could be able to see in one instant that the hypos were following a bolus or when a bolus was active, and the others trends upwards were when only basal insulin's active.
So you want to differentiate the effect of the basal versus the bolus,
right?
Which is a very good idea.
Right.
And fortunately to us, we see that in the last new CareLink 3 reports, there is already some work in progress to help us to differentiate the active insulin and the basal insulin further on.
All right.
Okay, so this is the daily overlay, or the overlay picture where you get the graphic representation of the blood glucose and the meal information. But you don't need only CGM in order to gain access to information during the downloads. It's also good for patients who's not using CGM, because we know that because of many reasons, some of that has to do with the price of the CGM. Most of the patients today, even though the evidence is there for its advantage, are not using CGM. So the downloads are also very informative also for those who are not using CGM and only using the blood glucose SMBGs or blood glucose monitors at home, but they're using the Wizard. In this case, as we see in the download in front of us, you can see again that the patterns during the day looks okay, but during the night when the patient was measuring his blood glucose, there is a hint that the basal rate is inadequate, maybe it's lower. Again, you do have also data regarding the meal data on the bottom boxes. And the meal data on the bottom boxes show you again that the pre-meal glucose is fine. That means probably the basal rate is not bad during the daytime. But the bolus is inadequate, at least in the morning, to overcome the high blood glucose excursion in the morning. Again, a question of is adequate basal or is it adequate bolus? This needs to go further on and to look at the daily details. We'll come up in a second because the next is the daily details again. So now we can go into details, specifically that specific day, to see if the issue is a bolus or the issue is a basal. And it also can give you the specific details of every bolus the patient made in a specific day. Is he using the Bolus Wizard? Is he overriding the Bolus Wizard? But it also gives you an insight on the quantitative difference between what he needs to have and what he gets from the pump. And what I mean by that if you go and to look at the lower second line, and that is the correction bolus from each bolus that he did, you can sum up and see that many boluses he needs to do additional 2.2 units, 1.3 units that throughout this day. If you sum up those who are positive and those who are negative, you can get some kind of a notion how far the basal insulin is from his need, or how much the total insulin is far from his daily needs. So let's go into also more specific questions which is very difficult if you're not using the wizard or you're not using the downloads. How to match insulin to carbs, or more specifically, how to do the settings for the carb to insulin ratio. Not a simple task. Usually what the physicians do is send them to the educators, right, or to the dietitian. Sure. But why isn't it will be fun to have a tool that we can do it ourselves, or that brings us the information straightforward? So how to assess the carb to ratio settings? So we have many ways to do this. One way is to look at the daily overlay. The bottom, it's the insulin, it's the meal data. And in the meal data, they're already organizing us the statistics on how much the patient average carbohydrate intake is, how much the average insulin doses is, and by doing the ratio, you can get straight to the amount of the carbohydrate to insulin dosage was used. If the patient was on target, let's say here, let's say the morning, it looks not bad, you don't have to change the settings. But let's say during the lunchtime, when there's a little overshoot, there's a bit over bolusing, then you look at what is used by the patient. Let's say it's 10 grams per 1 unit of insulin. And if this is an overshoot, then you tweak it and make it increase the ratio, let's say, of 12 grams to 1 unit of insulin. And this comes out straight from just looking at the data coming from the daily overlay. But you can also get data from looking at specific information from downloads on a specific day. This is a nice example when you can look at 2 meals. You look at the lunch or the late morning or late breakfast and the lunch meals. You look through the daily details and look at specific meals when the beginning of the meal was exactly in target, so the patient did not need to do a correction bolus. You look at this download, you can see that in both instances, the patient started the meal on target. But look what happened. While the use of the Bolus Wizard in bolus number 3 during the late breakfast, the patient used the wizard, and at the end of the meal, he was well controlled, showing that or hinting to the fact that probably this setting is right. During the lunchtime, it was the opposite. Using the wizard, doing exactly what the wizard told him, he went into hypoglycemia. Make you think to see if this is a recurrent effect to change the setting in this specific day. So you can get to the data looking at the big picture, at the overlay, or looking at specific days by looking and screening specific days. How to assess insulin sensitivity? Another major question. Not easy to do. We know how to set the pump at the beginning, but then how to repair it, how to change it, how to find how to change it according to the patient's control. So this we're looking at specific days where the patient is bolusing but not eating. So that's the opposite what we were looking before. So here is an example where the patient is bolusing, bolus number 1. He woke up late. He did not eat breakfast, but his blood glucose was high. And he did a correction bolus according to the setting of his pump. In this case, the patient was right on target. So after doing just the correction, he went down after 2 hours and he was in control, meaning or hinting to the fact that here the correction bolus is correct. You don't have to change this. On the opposite, look here at lunchtime at bolus number 2. In bolus number 2, the patient has not eaten for at least 3 to 4 hours. His blood glucose was high, and it corrected it without ingesting carbohydrates. So this is a pure correction bolus. In this case, correcting the bolus according to the wizard and according to the specification caused a hypoglycemic event. Again, hinting to the fact that it might be that the bolus correction is too high. You have to maybe modify it a bit. Again, it's oversimplifying, but it gives you some kind of a hint on what to change. Now we're moving into the time that more and more patients are going to use CGM or continuous glucose sensing, and we believe that most of the patients will eventually learn and to adapt this technology. And adapting this technology means that the patient needs to know what to do now when he has continuous glucose data flowing in. Because in the past, he used to look at data in a single way. Let's say he has 10 millimoles, and then to do what he has to do with 10 millimoles, to do a correction or not to do the correction according to what his plan is. But now he knows that he has a 10 millimole, but now he also knows that 10 millimole has a direction. It's either going up or it's going down. This will change the way that he treats the single number according to what the trend is. And we try to give him some tools in order to work with these new information about trends coming from the continuous glucose sensing. And let's look at the event in the circle. In this circle, the patient had a meal, which, using the bolus calculator, advised him to use a high dose of bolus. Let's say, I think it's hard for me to see from here, but let's say it was 12 units. But the patient actually showed that the trend of the blood glucose before the meal is rapidly decreasing. So he uses the algorithm that we teach them, or uses his own common sense, that if I am eating but the blood glucose is trending down, maybe we should decrease a bit the amount of the insulin that was recommended by the wizard, and that's exactly what he or she did. And by decreasing the bolus recommendation by, in this case, 2 to 3 units, he avoided and prevented a hypoglycemic event. So it also shows us that in this case, the patient is intelligent in the way that he's using the data and using the pump and using the technology. And talking about technology, it does give us also insight and technology and intelligence. It can show us also if the patient is using the pump and the sensor in an intelligent way. Look at this patient. Is he using it in an intelligent way? See, this patient woke up and his blood glucose was high, and he did a correction bolus. 3 hours later, he had all the alarms on. He had all the danger alarms put on, and he thought he was smart, and he was using another bolus to correct, and then another bolus to correct, and then another bolus to correct, seemingly that he knows he has all the technology, and he has sensors, and he's bolusing, but he didn't do the basic thing to do when you have 3 or 2 hours of high blood glucose, and that is do what is called the troubleshooting. Make sure that everything is connected right, you don't have air, you don't have bubbles, you don't have fluid running out of the catheter. He did not do that. He actually waited for more than 10 hours until he changed the settings. That tells you that even though he seems to be knowledgeable about using technology, in this case, he's not doing it intelligently, but you won't know it because we erased the name. Okay. The low glucose suspension that was mentioned before, a very important tool. And we use it to show our patients that how important it is for them, and now to make sure that they are not abusing this information. And I'll show you, and I'll try to explain what I mean. In this case, the patient had a binge of eating during the night, and he even drank at that time, and he bolused 10 units of insulin at that specific time. He went into coma, or slept through the alarms, and in the morning, about 4 hours later, he came out of the hypoglycemia. Somehow, and you don't see it here because there's some mistake, the low glucose suspension was kicked in. This is to show him that actually the low glucose suspension probably prevented a very severe hypoglycemia at this patient. While looking at another patient, this is a patient that during the daytime, his blood glucose reached the threshold, shut down the pump, but he didn't do anything. In this case, the patient liked the idea that the pump is taking care of hypoglycemia instead of just taking care of the hypoglycemia, ingesting carbohydrates, or doing whatever we teach them to do in hypoglycemia, but he let the pump be shut down, and only later he ate a big snack and so on, and he overshoot of the hypoglycemia. So the first case is to show the patient, to encourage him to use the sensor as it saved him during that night. In this case, you can understand that the patient needs some more education on how to treat hypoglycemia, also when he's using the low glucose suspension, because that's not the way that we want them to treat low glucose suspension during the day. I think it's time for us to go into specific cases, right?
Sure.
Is there any questions, or is there any questions from the...
No audience questions
No
at this
yet.
time. I think we could carry on.
Okay, so let's...
Well, maybe I'll ask a question.
Go ahead.
You know, I think that's so sophisticated how you took things step by step. Basal, food bolus, correction bolus. But there's so many situations where for example, that patient who had, I think, too much food bolus in the afternoon, they were getting low, and you might adjust up their carb ratio so that they're not going low later in the afternoon. It could very well be that their basal is too high through that afternoon, so if they didn't have a meal at all, they would go low, or if they have any more activity that day, they'd go low, and it wouldn't have to do with the bolus. And that may not matter. You can fix the bolus, and that will help fix their problem. But I kind of realized as you went through this, we do need to remind our patients one step at a time. Think about your basal, evaluate it as well as you can, find those opportunities in a day when you're not having meals, and compare two sugars, are they rising or falling? That kind of has to be taken care of before you can really do a great job at the bolus parameters. It's kind of got to be a step at a time, doesn't it?
Well, I do agree. We don't have the machines will not take over our job yet. We still have to look at each and change, and really, the point is really to do one step at a time, because it's very difficult to fan out between the basal problems and the bolus problems. And even though it seems to be simple, it's more simple using the downloads, but it's not trivial.
Yeah, actually, if I can, I'll take 10 more seconds. For that patient that the afternoon, they were getting lows after boluses, you can decrease their carb ratio, or I'm sorry, increase their carb ratio so that you decrease their food bolus. But as they leave the clinic, you may say, listen, I made that change. You're going to be protected from that kind of hypoglycemic event a little bit better, but that's a time of day where we need to understand better. Make sure that there's some day where you can evaluate your basal, that you've delayed lunch a bit or you've not eaten lunch, so that when we next meet, we can be sure that that decision was the right one. I think that's a good approach too, because we can't always put people through basal assessments, bolus assessments. We need to make some changes, and you've shown us a nice way of doing it. We can always remind them that this solution we think was the best one, but be on the lookout for lows that are happening when you're not eating, because it could have been too much basal as well.
So I will continue this thought, and using the downloads, it can also but pinpoint the area of discussion. Right. It's lunch. It's the post-lunch. We have many solutions to this issue. We'll try one solution, but then it helps us to focus on the problem at hand, on a specific time of the day. So we'll go ahead and see how it goes. And in this case, we're going to present two cases, real true cases. And during the presentation, we'll do a small pause, and we'll ask the participants to put in their inputs on what they would do according to their polling questions that we'll show you in a moment. So this will be a kind of an interactive part of this presentation. So let's look at case number one. This is a case of a patient who is in transition. That means he's moving out of the pediatric department into the adult world. This is a very crucial point, but many patients kind of lose their...
So what age is that?
It's between whatever, you know.
Oh, okay. Because I'm noticing this person's 23 for us. They would have already been lost in the adult system.
So in Canada it's a bit different, but there's many countries that the pediatric departments want the patients to stay as long as they can. They don't believe us, adult endocrinologists. And you see patients at the age of 35 still going into these rooms with the Mickey Mouses and everything inside, which is a problem. So we're trying to solve this by having a transition.
How is that a problem? I think that's great.
The
Mickey Mouse in the room, I would feel better with that as well.
But the chairs are very small.
I see.
So they have a problem with that. So let's look at this patient who is 23 years old, is not that old, and our tradition actually is from 17 to 25. He has type 1 diabetes from the age of 12, and he's using multiple daily injections. And his A1C is 9.3, not a rare occurrence, right? And he comes to our first visit to the transition clinic. That's how he looks. He's very, try to get some information out of this guy, and he wants to be better. He tells you, fix my glycemic control. Treat me. So my question for you, you're sitting in front of this guy. He comes with his blood glucose meter. He's out of control. He's downloading this. This is all the information he has. He's downloading this data. Just look at the data for a second. And try to think, how would you do, what will be your approach, and trying to understand what is the main reason for him to be out of control. And which we can go to the first polling question. Okay, So the first question for you, and you can answer this, is there any technical issues to tell the participants?
Well, I think in front of your screen, in a moment, you'll have the opportunity to select one of the options. We'll give you just a few moments to do that, and then Dr. Cohen will review the results.
So the question to you, if you remember the download, what do you think is the most common reason for this patient to be uncontrolled? Is it 1, insulin omission? 2, the patient is not measuring enough blood glucose with his blood glucose meter, or that the plan is not good enough? It has an inadequate insulin plan. We'll give you a couple of seconds to figure this one out.
We need some fancy Jeopardy music, the final Jeopardy music to happen right now.
That's your role.
Right. Yeah.
Make it happen.
I need to bring the audio in for the next session, apparently. So if everyone could just take a moment and register their vote, and we will soon see the results.
Again, if there are questions, they still can put in some questions, right?
Yeah, at any time you can be registering questions, and we'll address those if we can as we go through, but certainly in the latter components. So there we have our results of the first poll question.
So Bruce, are you surprised at the results of the polling question?
No, I'm not. I think I like the wording of inadequate insulin plan. That's what most people thought. So I'm not surprised. That looks great. Now, if you said there were a few capillary measures, but you would have had to have had eagle-eye vision to see the average daily thing on your screen. But it was actually that's one thing. He's kind of engaged. He's checking sugars, and if am I allowed to comment on?
All the time.
Sure. Okay. Actually, can we see the output?
You want to see the download, right?
The download, yes. Yeah. Well, in that
Can we
download.
switch back to the program? I'm sorry.
Actually, can everyone see this at home, or are we supposed to describe the results?
No, they should be able to see
so
this.
They see
here
it.
at the
So,
moment.
let's just sum this up. You see that the minority thinks that there's too few SMBGs, but the rest are probably divided equally between those who believe that there's insulin omission and some of them believe that the plan, that means the physician, is no good, or the plan that the patient is receiving is no good. So let's go to the download and let's discuss this harder. So this is the download. No, this is not the download. This is the download. 1 second. This is the download.
So, well, you're going to have a much more sophisticated interpretation, but I will tell you what I would, here's someone who's engaged. They're measuring blood sugars. It's 5 a day on average. And prior to dinner, this person has the best, not perfect, but the best blood sugars of the day. Some lows, some highs, but generally their best sugars of the day. I can tell that they're really struggling with food bolus because they don't need a correction at that time and they're rising by bedtime. I would focus the person on that time of day, focus on the time of day when they have the best blood sugars and now have a better plan for the insulin for carbs so that they're not rising so much by bedtime, and then we can see whether that begets better fasting sugars. So this person needs a better plan on food bolus.
So the question is, the dinner rise, the post-dinner rise, is because he's omitting insulin or because the plan is bad? And
well, if his plan is to omit insulin.
Yeah, you have an answer for everything. So I think the audience who's watching us were totally correct by the fact that they don't know which is the reason, because you don't have the data. You don't have the data. You only think you do know that he's measuring his blood glucose. So probably too low SMBGs is not the right issue and not the issue that you have to confront with this patient. Okay, you don't have to anger him by saying you have to measure more because he's measuring correctly. So in this case, you don't have the answer if it's insulin omission or bad plan. And I think that the audience were totally correct. So what did we do? So the next thing we did was put him on a plan, on a pump. Is this right? Yeah. So the patient is now prescribed an insulin pump, and he's beginning to be trained in carb counting and the use of the wizard. So when he comes back 6 weeks later, let's see if anything is changing, or can we now change our recommendation. So this is the download when he comes in 6 weeks. This is now we have additional information. So we have the picture of the blood glucose levels in the top box. We have meal information, but we also have bolus information. So this is the overlay report, and I'll show you additional. I just want you to look at that for a couple of minutes. And let's look at the adherence report. Is he measuring enough? Is he bolusing enough? Is he bolusing according to the plan? Is he changing the consumables enough? Those are the questions you get from the adherence report. And then, this is the setting. We'll leave this aside, and we go straight to the poll question number 2, which is actually the same question as before. So now, having the additional information, what do you think is the main reason for this patient to be uncontrolled? But still, he put in a pump. He did all the effort. And his blood glucose control was not that great. Is it the technological problem? Or now we can get additional information how to improve this. So again, the same polling question. Now that we know more data, is it an insulin omission problem, too few blood glucose measurements, or inadequate insulin plan? Go ahead and try to answer now once you have the additional information. I think we have a very good audience watching us. It's a pity that we cannot see them, right?
Yeah, I'm glad to know there are actually people on the other side of the screen.
Anyway, just to sum up the results, again, everybody now is quite convinced that the patient is actually measuring. The majority, the 93% of the audience believes and knows. It does not believe now. Now we know for a fact that the patient is very good in bolusing. He's not omitting bolus. He does exactly, and all his boluses is using the wizard. And then what everybody in the audience is saying is that the plan is not good. And remember, if the patient is very adherent to the wizard and is out of control, it's our problem, it's our fault that the patient is not in control. Let me go back. So, if this is the patient now that he is downloading, he's using measurements of blood glucose, he's very compliant with the wizard accommodation, he's changing the consumables according to the specifications, and he has this kind of a plan, then the issue is that now what we have to do is now start changing the plan. And I'll just go back, and now that we have the data, what will we do now with this patient? A lot of things, right? You want to comment? Or
Sure.
Go ahead.
Yeah, so the impression I have, most of the time, even on the top panel, you see when there's a sugar in target, the next one is generally high. Now that when we look at the meal overlay, that's not always true, but it's certainly mostly true for dinner. So he's under bolusing for dinner. So either the carb counting is off or the carb ratio is off. And so we can have that discussion, see what's more likely, and make that change.
Can you stop for a second here?
Sure.
Can we have an answer to the question, is it a carb counting issue or is it a bolus issue?
Only partially through an output. So
Right.
all we can know is what they enter by way of carbs. If he said he had 60 grams of carbs for that meal.
The average daily carbohydrate intake is 153. How bad he is?
Yeah, so either he's intentionally having lower than average daily carb intake. Now, if that was him in the picture, as he looked like a basketball player who listens to Rage Against the Machine, he needs a lot of carbs to feed those habits. So there's a good chance that he's undercarbing. But there's also, in discussion, you'd find out whether he's really pushing protein in his diet and minimizing carbs. Because it's true that some of our patients under best control do minimize carbs, not that it's necessary. So you're right. Carb counting is probably the key issue. And we often see that when dinner time has the most variability, because dinner time can be the most complex meal to count carbs for.
So my point of view is, having the data in front of you, now you can have a discussion. Now you have the issues at hand, then can you confront them, ask the patient specific questions, and deal with the specific issues. And this is the the power of downloads and web data management system. Okay, I think we had a point here.
Yeah, and actually just for you to know, like in my clinic, it's true that we could leave the downloads in the hands of a nurse educator and a dietitian. To me, it's critical that patients come into my clinic with that information, because I have 15-minute visits. If I have the outputs, I can make a decision about blood sugars confidently within a few minutes and actually deal with the important stuff. Otherwise, a pump patient with all this technology, I'm asking about trends, and that in itself takes about 30 minutes out of that 15 minutes. It makes the math impossible to actually see patients. So I agree with this. We put a lot of effort into downloads.
Good. I think we're ready to go to the second case, right? So the second case is going to be much more complicated and much on a higher level of interpretation. This case is now a pregnancy case of type 1 diabetic women. She's 34-year-old. She has 4 kids. She has type 1 from the age of 10. So she is a long timer on type 1 diabetes. She also has Hashimoto thyroiditis, and she has been on the pump therapy for 6 years. Luckily for us in our country, CGM, or continuous glucose sensing, is reimbursed for every pregnancy for 15 months, which is a good idea. So many of my patients, almost the big majority of our patients, are on pumps and CGMs at least during their gestation. On week 25, she comes to our office, and during pregnancy, we are seeing these patients in the high-risk pregnancy clinic, and we see them every 2 weeks. And we do a lot of measurements, and we do a lot of BPS or physiological measurements of the baby. And we're having already some hints that the patient's baby is increasing in the abdominal circumference, which is a bad sign, showing that maybe the baby is going into a phase of being large for gestational age, which can also lead to macrosomia, which is an endpoint that we are trying to avoid. Her A1C is 5.6%, which is not bad if she was not pregnant. But the pregnancy is a time that we need to be much more aggressive, and the time to fix the glycemic control is very short. So this is the case. This is the patient. Her blood glucose is not bad, but not good enough for this specific case. That means we need to improve the glycemic control in a short time and do it in a safe way. We really don't want severe hypoglycemia in 25 weeks of gestation. Now, this is the download of the patient. Remember Bruce's question before? How can we differentiate between issues with basals and issue with boluses? In this CARE3 download, which I did not discuss this before, and this is the opportunity for me to show you this, this gives you a bonus, a present for patients who are downloading and using CGM. We have additional reports, and this presentation, the presentation of the dashboard, we can see on the green lines on the top square, or that we have a green line which is continuous, and this represents the basal insulin, while you have another green line which is dotted, and this gives you a notion of the active insulin at those day-to-day changes during the 2 weeks that the patient was downloading. Again, you have the thick line, which is the basal insulin, and you have the dotted line, which is the active insulin representing the bolus, which might help you get into the question. Let's look at the hypoglycemia that the patient has between the hours of 4 to 6. You see there's a hypoglycemia there. And this is your question. You asked me whether it's a basal issue or a bolus insulin. And inadvertently, I have this download which kind of hints to the issue that there's a slight increase in the active insulin right before the hypoglycemia. Again, not 100% answer, but kind of makes you think that it is kind of more of a bolus issue than the basal insulin.
Yeah. Well, you see that in the overlay by meal, but even here that clinches it for the overnight period, where you see that she doesn't have active bolus, let's say, after midnight, that's responsible for drops at that time, not that she really has them. Here, she needs more overnight basal. And
wait, this is the polling question.
Oh, I see.
Okay, so let's go back to the question at hand. So this is the patient's download. Okay, remember she's a bit out of control. This is her daily overlay. As you can look, and you see at the top is the patterns of her glycemic control during these 2 weeks. The bottom are her meal information. And this is a specific day, which is a representative of the other days. Just not to overload us with downloads, this is a representative of a day of this patient. You can look at the way she's injecting her insulin during the night, how is she correcting it, and during the lunch or the late supper that she's eating at that specific day. So I'm going to show you again, and then we'll go to the polling question. So this is the big picture, the dashboard pictures, just showing you the daily blood glucose patterns, the meal patterns. You go to this, and this will tell you how she reacts in a regular day, and I think we'll go to the polling question. So the poll question now, we have 2 weeks to improve glycemic control. We have to do it very tight. And what will you, as her healthcare professional, do to improve? Would you change the overnight basal, the daytime basal, the carb to insulin ratio, or will you change all the above at the same time? It's not an easy question, right?
No, it's not. And I blurted out an answer, and
It's good.
Could have very well been wrong. Keep that in mind as you enter your choices.
The issue with pregnancy, again, is the stress of time. You don't have the opportunity or the ability to do one step at a time. You have to be much bolder, but on the other hand, you see them every 2 weeks. So it's a give and take. It's a kind of situation.
Yeah.
If everyone's had a chance to vote, we will tabulate your results.
So those are the results. Overnight basal got, I think, the most votes. Then the carb to insulin ratio. But actually, most of the viewers thought that this is a complex and you need to do more than one chain. So in this case, I think all the answers are correct.
Agreed. I might have biased through my comments that choices for overnight basal.
Give them credit. I think the audience is very,
No, I
keen,
agree,
and because now we can look at the data and interpret it in an easier way. Well, why did you go to the basal rate during the night? Why did you do first look at the overnight basal?
Yeah. Actually, I'll keep it brief, but you could argue either way. Actually, the blood glucose is pretty stable through the night. The average line is very stable. But overall, at the end of the day, she's struggling with overnight control. It would make some sense to have a bit more overnight basal because they're not on targets over that time period, nor are they for the fasting blood sugar. That's why.
So first of all, because it's the easiest way to approach is to go to the overnight blood glycemic control. It's clear, it's there, and it's very easy to address, and it needs to be addressed. So first of all, if you do it in a systematic way, if you look at the downloads in a systematic way, first fix the night time first, because it's easy, it has less inputs throughout the day, and it's clear that she needs an improvement in the glycemic control. During the night, increase her basal. Will that solve the problem? Probably not, because we still have large excursions during the lunchtime and the dinner time. Right. So how are we going to address this? So the audience said that there was a big, a lot of people who thought that changing the insulin to carbohydrate ratio is the answer. I want you to, again, to look at this data and to decide, let's try to fix the dinner and the lunch. Is changing the insulin to carbohydrate ratio the right approach to decrease the high excursions of these meals? Okay, this is a tough question. It's with the last question. Is the issue at hand a insulin to carbohydrate ratio issue? And if we just change it, by the way, should we increase the ratio or decrease the ratio? That we didn't get the answer from the crowd. But if you want to decrease the excursion, that means you have the ratio to go down. That means for every 4 units, for every, let's say, in this case it's 7, in order that the patient will increase the bolus, it has to change to, let's say, 6. But if you want to prevent the post-meal hypoglycemia, you have to do the opposite. That's a dilemma. The answer might be here. So look at this daily report for a minute, and then we go to the last polling question. So now that you know all the data, should we now improve? Should we increase the basal rate? Not to overcorrect lows? Or is there a problem with the time of injection? Should we tell the patient to take care to inject insulin prior to meals, or at least the beginning of the meal? What is your take on this last polling question? Pregnancy is not simple with type 1 diabetes, but the results are astounding.
So last question, everyone, get your answers in and we'll tabulate them. I'm not sure if you get an all or the above this time.
Yeah, no, we don't give them the... Okay. So, to increase the basal rate, that's a correct answer. To inject insulin prior to the meals is also a correct answer. Not to correct lows, not to overcorrect lows, again, is the answer. So, we're not asking knowledge here, what to do. It's just to show you that using the downloads, you can pinpoint all of these issues. And I think a lot of credit goes to those who also found out that the issue is to inject prior to meals. So if we go to, just a second, to this daily download, you can see that the patient in this lunch and in the dinner time does the first injection after the blood glucose starts to increase. And this sharp increase is usually a meal-induced increase and not a problem with the basal rate. So just looking at the downloads, they pinpointed a problem with this patient, and that is try to inject the insulin prior to the meals or even a bit earlier in order to improve the patient's control. And with that, I want to thank the participants and to see if there's any other questions for our panel.
Excellent. We do indeed have a few questions. Thank you, Dr. Cohen. So this question is actually for both of you. Knowing where your practices have been and where they are now, practically speaking, how would you say that the data management softwares have changed the way that you spend time with your patients? What do your appointments now look like, perhaps, compared to what they did once upon a time?
Yeah.
I'll answer this quickly. I do not know how to treat a patient who does not download. I don't know how to approach them. So we take care that all our patients, before they come to any one of our staff, if it's the physician, the nurse, the educator, the dietitian, everybody downloads in a specific place. And then when she comes to the office, we all access this from the server of the hospital, and we all look at the downloads as part of our daily routine care of our patients.
So actually, I guess I've already answered this question, that we emphasize that in our clinics, even if it's a physician visit. For me, how does it change things? Well, I'm spending less time pushing people's pumps, button pushing to write down basal rates, carb ratios, correction ratios. It's right there on a device setting sheet. And then I get the mode or the overall picture of blood sugar control from that, from the modal day average. And the other things, I have a quick view summary, which is more for my purposes. And then, sorry, what's my last one? The quick view summary, the modal day hourly, the device settings.
The daily.
Oh yeah, sorry. And then I do look at just a week's worth of the logbook so that I can get into the daily routines. So my patients come to know that's what I want to see, and I ask them to download and review at home. Do a diabetes rounds every couple of weeks where they look at those and understand those outputs so they can discuss them with me.
Very good. So, I mean, it certainly sounds like it's integral in both of your practices. A couple of other questions that might be a little more particular to the case study. Dr. Cohen, for the pregnancy study, certainly as diabetes educators in Canada, and I'm sure beyond, we are really trained to hone directly in on hypoglycemia. And that particular patient did have a little bit of section of hypoglycemia there. I'm wondering if we had handled it a little differently, what our outcome might have been. We might have gone straight to that, noticed that there was more active bolus at that time, and perhaps pulled a little bit back on the bolus. Wondering what your thoughts might have been about that different approach.
Well, this goes into the issue of treating diabetes in pregnancy, because it's a bit different than the routine way that we treat. Because in pregnancy, hard to believe, the hypoglycemia has no teratogenic effect on the fetus, unlike the hyperglycemia. It's not good for the women. You don't want the mother to go into hypoglycemia. It can induce earlier labor and so on. So women with pregnancy are used to have more hypoglycemia. And in general, women who are pregnant, their blood glucose, the average non-diabetic patients, the blood glucose is lower. So you have to get used to lower blood glucoses, lower A1Cs in pregnancy. So the focus is more on the hyperglycemia, but again, we will not neglect the hypoglycemia. But follow up on that question, that important question is, in this case, we didn't have time to look at the pump setting. The settings of the pump, we did not open all the alarms. Now that I'm pushing to a more aggressive treatment, I would then make a point of opening the low glucose suspension and the low alarms to prevent what you're saying, because I cannot eradicate. And if you try to eradicate the hypoglycemia in pregnancy, you're going at the end have more macrosomia and more large for large for gestational age.
Makes sense. And actually, while we're on the topic of hypoglycemia, I mean, I think as we look at tightening patients' control as much as we and they can, some hypoglycemia is going to be impossible to avoid. So could I get your both of your perspectives? I mean, if you have a patient come in who are working to titrate their doses to get their control better, what would be an acceptable amount of hypoglycemia? I think that where this is coming from is that we might see some educators and healthcare practitioners focus so much on the lows that we end up sending them a little higher and therefore may erode their A1C a little bit. So I hope that question makes sense.
Yeah. Well, I don't think there's a percentage value. Obviously, it's, our goal A1C for most patients is 7% or below outside of pregnancy, without troublesome lows. So troublesome lows mean those that affect judgment, that require assistance from people around us or, of course, from emergency medical services or hospitals. So what's the proportion of blood sugar? If someone has 3.9 frequently, that's actually, frankly, not hypoglycemia. Our targets are 3.9 to 7, generally before meals and at bedtime for the non-pregnant adult. So I don't know how to answer that as a percentage. I don't use a percentage that's unacceptable as a threshold of lows. For me, it's whether they're manageable and daily functioning, and that they're not troublesome lows.
I would just add also, is that not all the low, everything between below 3.9 is not the same. You can also differentiate between the very, very low, the low, and just on the verge. So you want to really want to prevent the severe hypoglycemia. This is the main goal. Having some hypoglycemic during the day, you ask any diabetic patient, he has many of them. It still does not prevent him from functioning. I like to prevent hypoglycemia, especially for patients that are so afraid of this hypoglycemia that they keep their A1C too high. Yeah. That's when I particularly want to prevent those hypoglycemia, to make them more enthusiastic and motivated to improve the glycemic control.
You could say that the ASPIRE study results wouldn't have been meaningful if the primary outcome, which was area under the curve of hypoglycemia, which shows some intensity, granted, if it weren't also corroborated by the clinical events of severe hypoglycemia. Obviously, you can't power a study of that. You hope that people don't have lots of clinical events, but we didn't see them in the low glucose suspend group, whereas there were a handful in the control. Yeah.
Very good. Just a couple of more questions before we wrap up. These are small technical questions. In terms of the split of basal bolus insulin delivery, how much attention do each of you pay to that? I know that 50-50 is a little bit of a rule of thumb, although I suspect that for a lot of patients we need to perhaps put that aside. So could you maybe comment about how you feel about the split and how much attention you pay to it?
Yeah, actually, if I can answer that first. So it's on, for me, it's on that version of the quick view summary. I like to get a look at that to see if basal's in the range of 40 to 50%, just as an initial screen. If it's dramatically out of that range, it could very well be that it's there for a good reason, like the person on a low-carb diet. We expect them not to have lots of boluses by day. But it gives me a quick screen. Just like when I look at the basal profile, my quick screen is roughly those hours of 3 a.m. to 9 a.m. Do they generally have their higher rates rather than noon to 5 when I expect them to be lowest? So it gives me things to see at face value. It gives me a starting point. So that such a patient who doesn't have that higher basal overnight and is struggling with fasting hyperglycemia, I know that that's probably one of the reasons. Or they have their highest rates in the afternoon and they're struggling with afternoon hypoglycemia, I know that's probably one of the reasons. And the basal split gives me an idea of that as well. So it just starts me in thinking about the patient.
Nothing to add, yeah.
Nothing to add. Excellent. Thank you. And the final question is one that's come up a little bit in recent history about the active insulin time. So I think historically it's probably been set at 4 hours for the most part. I'm wondering whether or not either of you might suggest setting it a little bit shorter or a little bit longer. I know that some healthcare practitioners are now setting it at 5 hours instead of 4, and whether that might make a difference.
So I'll give you my take on this. Now, it's a difficult answer. It's an easy question and a difficult answer. Well, it's very hard to quantify this in a very systematic way. So what we usually do is look at the average boluses, because we know that the bigger the bolus, the longer the activity of that specific bolus is. So if somebody is using 2 to 4 units as their average bolus, it's going to be short 3 hours, 2 hours. If somebody's using 10 to 12 units, it'll be 4 to 5 hours. So we're looking at actually what is the average bolus to define what is the active insulin. But I don't think there is the right way to do this. But I would love to hear your intake.
Yeah, actually, I hadn't even thought about it in that way. That's really wise. To me, the concept of active insulin time is such a good concept to begin with. Whether it's 3 hours, 5 hours, 4 hours, is probably not going to contribute so much to the patient. But I agree with you that the size of the bolus will influence its duration. So for me, I think the concept is so good. If someone's struggling with lows when they have boluses close together, maybe it's because they've got a carb ratio that's too aggressive or a correction ratio, or their target's set too low. There's so many things we could change, and the active insulin time is one of those things. So in my practice, just to get by, I tend to like to keep some things constant, and so I tend to like the active insulin time at 4 hours and just not make that the big controversy. But the patient who's getting hypoglycemia, I might ease up on all of their parameters, extend the active insulin time, raise a target, raise a sensitivity, for example. So, but arguing between 4 hours and 5 hours, I'm not sure we're going to benefit our patients so much by that degree. The concept is already such a good one. I think the difference of an hour or two is not going to make the world of difference.
Yeah, it's a matter of priority. So it's a maybe academic question, but from a practical point of view, the active insulin is very slow in the contribution to big issues in control, I would say.
Yeah.
Excellent. Thank you. Well, I think given that we've run a little bit over, we will wrap things up for this morning. So I'd like to thank Dr. Perkins and Dr. Cohen for your time and for your expertise. I think it's been a wonderful session this morning. I'd like to thank our viewers. If you have any additional questions, you can submit them now momentarily. And I think with that, we will wrap things up. Thank you very much.
Thank you.
Thank you. I learned a lot.